Being a first presenter, I welcome all of you in first annual NICBD Interventional Cardiology course over here. And I thanks to authority who has given me opportunity to present the talk over here. My responsibility to present coronary artery revascularization guidelines. Excellence of gift lies in its appropriateness rather than its values. Learn when to be patient, when to be aggressive. This is the theme for all the interventionists. Once you learn about it, you will be a safe interventionist. I am going to present the most recent one guidelines, which are 2021 ACC AHA SKY guidelines for the coronary artery revascularization. When a patient who presented to emergency department or OPD who needs revascularization, equity is the class 1 indication. All the clinical decisions should be on the basis of clinical, not on the basis of race, sex, or ethnicity. Class 1 indication to maintain the equity. After getting the informed consent, that means all the pros and cons of the revascularization study should be informed to the patient, and then the approach should be patient-centered. All the preferences, the comorbid, the patient socioeconomic status, the patient literacy rate, the patient the life expectancy, all the things which should be kept in mind, and patient preference should be prioritized, and then a collaborative decision should be made about the revascularization strategy, and then to go ahead for the revascularization process. Third team, this is one of the most important. This is class 1 indication, either in dubious cases or in complex cases. This is class 1 indication when you involve intervention cardiologist, clinical cardiologist, and CT surgeon. This is the third team which is on the basis of mutual respect, collegiality, and it is also based on the services for the excellence. It should be daily to weekly, depends upon how much the burden of the patients in your setup, but it should be also on ad hoc basis. When there is an emergency, you have to call for the third team and to discuss about the patient. These are the concerns which her team look for: the coronary anatomy, the comorbidities, the procedural factors, the patient factors. These are the things. These are the things that have to be looked by the her team. So now we are inching towards the revascularization guidelines. The guidelines, these are giving us a track. It is a lengthy topic, so I try my level best to make it digestible in 25 minutes of period of time which is specified for me. So going to the STEMI guidelines, the revascularization for the STEMI revascularization, that is all about the time, that how the patient, how much from the onset of the symptom patient reaches to the emergency department. If a patient who reaches to the emergency department within 12 hours of the symptom onset, primary PCI, that is the class 1 indication. But if PCI not feasible, then if large area of myocardium is affected, then CABG is class 2A indication. Remember, the CABG, emergency CABG, that has high mortality, but as you have to salvage of the myocardium, so emergency CABG should be acceptable with acceptable risk. If a patient who reaches to the hospital after 12 hours of the symptom and patient is in cardiogenic shock, if PCI is feasible, then primary PCI, that is class 1 indication. If PCI can't be feasible because of the so many factors, especially when patient having PCI related complication like the VSR, the patient having mechanical complication like the MR, pathological MR, because of the pulmonary machine infarction or rupture or cardiac rupture, emergency CABG is class 2A indication. In cardiogenic shock, you have to forget about when the symptoms start. Irrespective of the time delay, you have to go ahead with primary PCI and cardiogenic shock. Patient having ongoing ischemia, heart failure, electrical instability, in this type of the patient, the going ahead with primary PCI, that's class 2A indication. Symptom onset after 12 hours to 24 hours. If a patient is even stable, going ahead with primary PCI, that's class 2A indication to reduce the infarct size. But if a patient who reaches to the hospital after 24 hours, if he is asymptomatic, then opening of total occluded artery is class 3 indication. There are other scenarios like when a patient who got deperfusion stage G, fibrinolysis stage G initially but failed, going ahead with rescue PCI, that's class 1 indication. Emergency CABG, usually it is indicated in salvage cases. You had no option for primary PCI, you had no option for the CABG. So for that reason, no reflow is one of the most important phenomena. It can give nightmare to the interventionist all over the globe. So for that reason, the prediction of no reflow, that is very much important, because we can prevent it but can't purely treat it. This is one of the scores. We are very proud from the NICVD. We have given this RK score to the globe for the prediction of no reflow. So assess the patient for the no reflow in emergency department in cath lab. It will help you to predict prediction of no reflow. It will enable you to protect. It will enable you to prevent from the no reflow. That will help you to put you in a safe zone for the patient. When you open up the infarcted artery, what you need to do for the artery which is significantly obstructed but non-infarcted artery. In these type of the condition, look at if the patient is cardiogenic shock or not. If yes, you haven't to go ahead with multivessel PCI. There is trial, culprit shock trial, which has clearly shown the patient who presented with cardiogenic shock, if they went through the primary PCI to the multivessel PCI as compared to the only culprit vessel PCI, the patient who went only to the culprit vessel PCI, they having decreased mortality and decreased need of renal replacement therapy at 30 days, and at 1 year there is no difference in mortality in both of the arms. So it is advisable to defer the multivessel PCI in patient with cardiogenic shock. But if a patient who having significant obstructed non-culprit vessel and large area of myocardium is involved, then go ahead with heart team approach and stage PCI or stage CABG is recommended. But when large area of myocardium is not affected, then medical treatment is to be optimized. Non-ST elevation MI. Patient admitted with non-ST elevation MI, and aim is to reduce the mortality, cardiovascular event and improve the outcomes. In these, if patient is cardiogenic shock, refractory angina, hemodynamic or electrical instability, in such type of scenario, you have to go through the immediate early invasive stage, that's class 1 indication. If you assess the risk stratification of the patient and patient proved to be high risk, like Grace score which is 140 or more than 140, in this type of scenario, going ahead with early invasive stage within 24 hours of the hospital admission, that's class 2 indication. Patient stabilized, and stabilized patient, when patient at the low or intermediate risk, then class 2A indication to go ahead with invasive stage before the hospital discharge. Stable ischemic heart disease. In these type of the scenario, the aim of treatment to improve the survival, reduce the cardiovascular outcome and improve the symptom. When a patient who is on the medical treatment but ineffective medical treatment is still having recurrent angina, then revascularization stage is class 1 indication. Patient with stable ischemic heart disease having left main and he or she is CABG feasible, surgical feasible patient, going ahead with heart team and CABG, that's class 1 indication. Patient having no left main but multivessel coronary disease, in such type of the scenario, assess the LV, and in severe LV systolic dysfunction, that is class 1 indication. In mild to moderate LV systolic dysfunction, that's class 2 indication. But if a patient who having normal LV with complex coronary disease and no left main involved, go through the heart team and opt for the medical treatment that is based on the ischemia trial. Because of the time shortage, I am not going to in details about this trial, but definitely this is one of the robust trial which have given us the guidelines track. There are certain conditions in which we have to decide whether the PCI or CABG, which one stage is feasible for the patient. Prioritize, which one to prioritize. Like the patient that having complex disease, like the patient having left main or patient having the high complexity of coronary disease. It is class 1 indication to choose cabbage over PCI to improve the survival. Multivessel patient having complex coronary disease like the bifurcation, tortuosity, the calcification, the trifurcation, these type of the patient, it is and sentence score more than 33 in these type of the patient, cabbage over the PCI for survival improvement, that is class 2A indication. Another patient like the patient diabetes, patient having diabetes is very risky, very much difficult to treat, because diabetic patient that having extensive disease, luminal diameter is too short, they having rapid progression of the disease. In such type of the patient, for the longevity, always it is recommended the patient, those having diabetes and multivessel coronary disease, go ahead with cabbage, putting a lima in this type of the patient that having more survival benefit as compared to the PCI that was completely proved from the freedom trial. In patient with diabetes and multivessel coronary disease, but they are not suitable for the cabbage, in those patients preferring PCI, that is class 2A indication. Patient having previous cabbage, then what to do? In previous cabbage, in patient that having previous cabbage and lima to with patent lima to LAD, then PCI to the native vessel or PCI to SVG, that's class 2A indication. In patient that having cabbage, refractory angina, and you have option that lima is available option for conduit, that in such scenario class 2A indication to go ahead with redo cabbage. Patient with DAPD adherence, this is one of the most important talk for counseling session and assessing for the patient pre-procedural. If a patient who is not going to adhere with DAPD because of the medical condition or because of any other reason, it is always advisable to choose cabbage over PCI, because PCI without DAPD can give you a fatal and lethal consequences. In other scenarios, there are certain special population when it comes to the emergency department, we have to be more vigilant, like pregnant patient. And pregnant patient, especially in STEMI, usually the pregnancy usually caused because of the spontaneous coronary dissection. Once you have ruled out the spontaneous coronary dissection, then going through the PCI, that is class 2A indication. If a pregnant patient comes with any non-acceleration MI, in such type of the patient, it is reasonable to go ahead with PCI when medical treatment fails to treat the life-threatening arrhythmias. Patient that having the chronic kidney disease, because chronic disease itself is high risk, it increases the mortality, and mortality in CKD patient, that is always inversely proportional to the creatinine clearance. So for that reason, every effort you have to put in to decrease the acute contrast-induced acute kidney injury in this type of the patient. So going ahead with invasive strategy in this type of the patient is class 2A indication, but always you have to measure the risk versus benefit ratio in patient with having the baseline CKD. But this is the most important thing which I am showing with this. In asymptomatic CKD coronary disease patient, prefer the medical treatment, going ahead with invasive strategy, that's class 3 indication. And these are the measures usually you should take before going to the intervention in CKD patient. One thing most important I need to mention over here, that is this one. What is this? Whenever you refer the patient, you getting the input from the nephrology department, usually they use N-acetylcysteine before the cath, so it is not advisable. Patient going for the non-cardiac surgery, apart from the emergency surgeries, in elective procedures, in a patient those does not having left main, those does not having complex coronary disease, in such type of the patient, going ahead with routine revascularization strategy in such type of the patient, that is class 3 indication. Ventricular arrhythmias, most of the time we are getting calls from the department that patient having arrhythmia and please go ahead with invasive strategy. You have to think which type of the arrhythmia is, monomorphic VT or polymorphic VT. In polymorphic VT usually denotes that this is the ischemia and revascularization strategy to decrease the ischemic burden, that is class 1 indication. But if a patient who having monomorphic VT, that is usually because of the scar VT, going ahead with revascularization strategy, this is not a wise decision. It's class 3 indication. SCAT, spontaneous coronary artery dissection. Still the guidelines are unclear about the proper treatment about this treatment. Going ahead with revascularization strategy in spontaneous coronary artery dissection is class 3 indication, because it is because of the intraluminal hematoma which compress the lumen, and if you go ahead with PCI, that can propagate the dissection. If you're going ahead with cabbage, more than 30% of the acute graft failure rate has been detected. There are no randomized control trials, but whatever the case report we have, that is. The other one, general issues for the PCI that are a radial or femoral approach, which should be, yes, radial is class 1 indication to go ahead with every PCI, but still there is unanswered question in guidelines. In radial, in opting the radial axis, that reduces the mass, that reduces the bleeding event, but it does not increase the lung survival or mortality benefit. But there is one unanswered question in radial point of view, that is radial, it is second most important conduit for cabbage after the lima. So whether we should go ahead in those patients in which we suspect that this patient will go for the cabbage and going ahead with the radial axis is good or not, still this is unanswered question from the guidelines. Choice of the stent, yes, obviously this is a priority, is class 1 indication to go ahead from the is preference to the BMS to prevent the restenosis and stent thrombosis. The other scenario, the patient going IVAS, that is class 2A indication to assess the lesion, to assess the length of the disease and stent apposition, that is class 2 indication to go ahead IVAS. Another modality which is OCT is class 2A indication to for the lesion assessment. OCT is also 2A indication, but OCT it is not indicated in ostial left main. Thrombectomy, routine use of thrombectomy is class 3 indication. Calcified lesion, prepare the lesion. When you suspect that patient having heavily calcified, preparation of the lesion, that is class 2A indication. Patient having SVG disease, it is class 2A indication when you going to treat the SVG with percutaneous intervention. Embolic protection device is class 2A indication. Always try to open native vessel if it's feasible, or PCI to SVG. But if it is CTO, it is class 3 indication to treat with percutaneous treatment. But sometimes most of the CTO expert, they uses collaterals from this for treating of the CTO. Patient that having restenosis, choose the 1 days or another days or cabbage, that's class 1 indication. Hemodynamic support before going to the complex PCI, that's class 2B indication. Every patient who is going for the complex PCI putting a hemodynamic support device, this is class 2B indication. Medical treatment post PCI depends upon in which setting you have put the stent, whether ACS or non-ACS. If ACS, at least 1 year you have to give DAPT therapy, and beyond 1 year you have to assess the ischemic versus bleeding risk, but it is class 2B indication to maintain therapy beyond 1 year. BMS, DACE, in stable ischemic heart disease, if you put DACE for 6 months at least, you have to give DAPT. And then cardiac rehabilitation, that is class 1 indication. Comprehensive cardiac rehab program, home-based or center-based, that's class 1 indication. Educate the patient about the cardiovascular risk factors. That is very much important, because once the secondary prevention program, that should be robust, so that patient should comply to those and reduces the recurrent infarction or MACE. Smoking cessation, that's class 1 indication. All the measures from the behavioral intervention to the pharmacotherapy, the counseling, the whatever you need, you have to put your effort, 100% effort for the smoking cessation. Psychological intervention, most of the patient who comes to our hospital after primary PCI, when they when we attend those patients in our OPD department, they alive from the heart, but usually they are dead from the mental point of view. Usually they are depressed. You have to counsel. The counseling session, that is very much important. The cognitive behavioral therapy, the psychological therapy or pharmacological therapy, whatever you need to counsel the patient, and you have to put your effort to make patient happy. Traditional risk factors. Each and every patient who going through the intervention, the patients that should be screened for these type of the risk factors, which are the bulk of the factors, and these are the factors: the diabetes, smoking, obesity, physical inactivity, hypertension, dyslipidemia. These should be increased, and these should be intervened. These are the unanswered questions. Still guidelines are not clear about this. The ACC guidelines, like the left ventricular dysfunction, the patient, the cabbage from the state trial, there's a good evidence that going ahead with cabbage in LV systolic dysfunction, that's good result. But what about the PCI and LV systolic dysfunction? Unanswered question yet. Spontaneous coronary dissection, cabbage or PCI? Which one is best? It's still unanswered question. Myocardial bridging, surgery, medical treatment? What is the future of surgery in myocardial bridging? It's still unanswered question. Using radial artery can do for after the radial artery catheterization. When you hit the radial artery, when it will heal and will be ready for readily available for the surgery, it's still unanswered question. Completeness of revascularization in multivessel coronary disease. Hybrid coronary procedure, Lima to AD and PCI to other native vessel. Unanswered question. Revascularization before the valve procedure. Most of the TAVI procedure we are doing. Initially, we are going through the percutaneous treatment to the coronaries and then going to the TAVI. What is the fate of this? Unanswered question. The revascularization before the organ transplantation. One another thing, the patient who are on the warfarin, we people are in the era where patient having the valvular heart disease, having the atrial fibrillation, they are on the anticoagulation. Patient on the anticoagulation and coming for the primary PCI or SCAs, DAPT along with NOACs or warfarin, how much, when, how to deal ischemic versus bleeding risk? Unanswered question in ACC guidelines. When it comes, we have to wait for the next session for the guidelines, ACC guidelines. Till that, thank you very much.